I'd like to thank Dr. Pratunchak for being here and hand it over to him. He is our um, pediatric cardiologist over at Hawaii Pacific Health. Thanks for being here today.
So welcome everybody. As Summer said, I'm a pediatric cardiologist, also adult congenital cardiologist. And this one is totally about, I keep admitting people. Is that okay in the meanwhile? They are in the waiting room.
I can do it for you. No
Oh,
worries.
okay,
Yeah.
thank you. So this will be about syncope and chest pain in pediatrics. I don't have any conflict of interest, and here are my objectives that was listed before. So we're gonna look into chest pain and syncope more deeply. So I would like you to be able to identify the hallmarks of cardiac chest pain. That is important to refer, further evaluate, and not reassure, so to say. Then also we'll go over various types of syncope and then gonna zoom into cardiac origins of syncope. And then hopefully by the end of this talk, you will be able to initiate the appropriate workup or even the management for chest pain and syncope. So here it is. We're gonna be suspicious all the way through. Here is Peter Sellers from Old Pink Panther, who said that I suspect everyone and I suspect no one. That's exactly what happens with chest pain and syncope. Here is an excerpt from an article that I shared with Summer, and I think this article and the references will be at the end of my slideshow, so you can take a picture of it if you want to, or I can share it with you. This article is from Boston Children's Hospital. It was published in 2011, but I think even 12 years afterwards, it's pretty relevant, and this focuses on evaluation and management of syncope and chest pain in pediatrics. So this is the number of patients, children with chest pain and syncope who went to Boston Children's Hospital Pediatrics, and you can see it more than doubled from 1998 to 2011. And that trend continued to the extent that now it's one of the most common visits in peds cardiology. So let's start with chest pain. The big statistic says that about 1 in 5 children will experience chest pain during their childhood. I think it's even more than that. And it's quite common that they go to the ER with that. About 1% of all ED visits comprised of chest pain. And you can see somewhere between 5 to 10% of all pediatric cardiology visits, it's because of chest pain, depending on which vicinity you live in and which academic center they are measured at. All in all, it's the number 3, so the third most common reason for pediatric cardiology visits. Number 1 is murmur, number 2 is syncope, which we'll talk about, and number 3 is chest pain. But even though this is so common, it is less than 1% that the chest pain is truly caused by a cardiac etiology. So that's why my subtitle is Finding the Needle in the Haystack, because we need to fish out that less than 1% cardiac origin chest pain. So now I would like to go through exactly why, what kind of reasons or what kind of etiology results in chest pain that is a cardiac etiology, and what to deal with it. So I'm going to go through this exactly the same way I go over with a patient who comes to see me because of chest pain. And the way I go over it, I almost never need to tell the mother or the parents or the patient, him or herself, that, oh, by the way, your chest pain wasn't a cardiac origin, because once I describe what things can cause chest pain and they have a cardio or cardiovascular origin, they understand that their chest pain wasn't of a cardiac or a cardiovascular origin. So let's just go like I would do it with a patient. So I usually tell them that there are 2 major cardiac reasons for chest pain. One of them is inflammation around your heart, so pericarditis or perimyocarditis. The other is when you have lack of oxygen going to your heart, such as myocardial ischemia and infarction. I put there supraventricular tachycardia too, because very rarely um, little kids cannot verbalize what was happening in their chest, and they tell their parents, oh, I think I had pain or it was sore. A lot of times that is actually palpitation. And you need to be a teenager to be able to verbalize it or articulate it. A lot of times, in little kids, 5 years old, 6 years old, even 7, 8 years old, sometimes they just say it was sore. So I have seen patients who said it was sore, but at the end it wasn't sore, it was palpitation. So that's why I put SVT there. But truly, what comes as chest pain, it can be pericarditis or myocardial infarction ischemia. And vascular origin for chest pain is aortic dissection and pulmonary embolism. So let's just go over this one by one, and then it's very simple to see whether that chest pain was any of these four or not. So let's go. Pericarditis, perimyocarditis. So my question is to the parents, it's like sore throat. How long does sore throat last? Well, sore throat lasts like a day or two or three or four. So when you have pericarditis or perimyocarditis, inflammation around the heart, does it last for 2 minutes? Not a chance. It lasts for a day or a couple of days. So when somebody comes with a chest pain that lasted half an hour or 2 minutes, it cannot be pericarditis because those last usually more than a day. These are rather rare in pediatrics, usually idiopathic, mostly viral, sometimes could be associated with other rheumatoid conditions or disorders. And so basically it's just the inflammation around the heart. The pain is precordial, right in front of the chest. It can be substernal too. It changes with position. So the hallmark of this kind of chest pain is when you lean forward, the chest pain gets better. But the most important part is that it lasts at least a day or several days, and it's only relieved by anti-inflammatory, or eventually it can resolve without any intervention. So the inflammation of the pericardium actually, that inflamed pericardium releases bradykinin and substance P, and those two are irritating the nociceptors that are coming from the phrenic nerve and the intercostal nerves, which actually innervate the similar region of the skin and the musculoskeletal areas. So that's why, because the pericardium is right there and is innervated by the same nerves that go into the region where the heart is, that's why the pain is right in front of the heart or in front of the chest or sometimes even the diaphragm. That's what hurts in these patients. Again, most important is it lasts a day or two or even more. Myocardial ischemia or infarction. So how long does that last? Can it last 2 minutes? It's not a chance. If you have ischemia, it lasts a minimum of 30 minutes. Even adult stable angina, it lasts minimum of 30 minutes. But usually it lasts half a day until it's relieved by some medication or rest. So this is really rare in pediatrics. There is no condition besides Kawasaki disease and congenital coronary artery abnormality that will give you ischemia and infarction in pediatrics. I've never seen, and I'm not gonna see ever in my life, an atherosclerosis in pediatrics. It doesn't happen. It doesn't matter how high your cholesterol is. That usually starts in teenage years or in 20s and manifests only in the late 20s or the 30s. So it's never going to happen in pediatrics. What happens in pediatrics, if you have an uncontrolled Kawasaki disease and you have a giant dilation or stenosis, that can give you myocardial ischemia and infarction. But that usually is very well known. It's not something that got missed before. And the only thing that can come out of the blue is congenital coronary artery abnormality. Again, that is extremely rare, but that's what we have to keep in mind. And so This is more like a dull and vague pain. It's kind of all over the chest, radiates to the neck, left shoulder, left arm, and only relieved by therapy. So does this happen in front of your chest? Nope, this is not over there. So why is that? When you have myocardial infarction, and here it is in the middle, that area actually dies. So only the penumbra, the outside region where there is still viable tissue, that's the area that releases bradykinin again and adenosine, and that's picked up by the nerves that innervate the heart. But these nerves don't go into the phrenic and intercostal nerves. They go into the spinal cord, the thoracic spinal cord in the dorsal ganglia, which are then related to reflective areas, the skin innervation from going into that same thoracic region. It's coming from the left arm and the left shoulder and even the neck. So the low cervical or high thoracic areas that receive these pain signals. And that's why when you have a true cardiac pain because of myocardial ischemia, it's not related to the front of your chest. It's related to your neck, left shoulder, and left arm. Again, this is not something that lasts for 2 seconds and absolutely not for 2 minutes. So I will say that every single time, because you will see when somebody comes to our office with chest pain, I don't do any testing most of the time because it's all in the history. So the next one goes to aortic dissection. So this is now extremely rare because it has to happen in the setting of Marfan syndrome, Ehlers-Danlos syndrome, Lewis-Dietz syndrome, some aortopathy syndrome, which usually have significant clinical features, because if it's severe enough to cause aortic dissection, it really has to have clinical musculoskeletal features. And on the top of that, yet again, I have never seen a child having aortic dissection between 1 and 18 years of age. It happens in early 30s and 40s in those affected individuals, but I have never seen a child having this. So again, this is extremely rare. It's an excruciating pain in the middle of your chest radiating to your back. It results in unstable hemodynamics. In fact, most of the people die with this. So again, is it a pain that lasts 2 seconds or 2 minutes? No, it's not. It does not resolve until surgery. So it is when the blood extravasates coming out of the aorta into a dissected area, and then it releases tremendous amount of bradykinin histamine from the aortic wall. And that aortic wall is innervated by sympathetic sensory nerves that go to the thoracic spine, and that's why you have an upper anterior chest pain or actually a back pain, because that's where these nerves are referring to. So aortic dissection, again, does not go away, doesn't last 2 minutes, doesn't last a couple of seconds. It lasts until the surgery is done or the patient dies. So that's not a usual occasion in pediatrics. And the last one is pulmonary embolism. Now, this is extremely rare. It needs to come with some coagulopathy, sometimes drug-induced. You have to have an indwelling catheter, some patients who are hospitalized, or a patient who had a heart surgery. So it does not happen in healthy individuals. The chest pain usually happens on the side, not in the middle. It is coinciding with difficulty of breathing, a lot of times hypoxemia, so dropped oxygen saturation, and this does not resolve until therapy is administered. Does this last 2 seconds? No. Does it last 2 minutes? No. Never lasts 2 minutes. It lasts until it is helped. And again, so pulmonary embolism, what hurts here? So again, same substance, bradykinin, substance P, and histamine is released in the lungs, in the area that is dying, and it's picked up by nerves innervating the pleura. Lungs don't hurt, the pleura hurts. So whatever nerves innervate the pleura, that's what will feel the pain. And these sensory somatic nerves are usually going together with the intercostal nerves. So that's why the pain is related in the exact location where the pulmonary embolism happened. Does it hurt in front of your chest? Not really. It hurts on the side. So again, just a summary quickly. Pulmonary embolism, aortic dissection, these are the two vascular lesions. They don't go away. In one of them, you can die. The other one can also give you death, but then they don't go away until therapy is administered. The other two cardiac lesions or cardiac etiologies is myocardial ischemia and pericarditis. And once I explain these four scenarios to the parents, they clearly understand without anything else that, oh, well, yeah, I don't think so my child had any of those because the chest pain lasted 2 minutes. It was right in the front. It was difficult to breathe, but then it went away. So no, my child did not have any myocardial infarction for 2 minutes and then nothing else. So that's usually the spiel that I give to every patient who comes in with chest pain. So let's just go into a little bit of statistics more. In that article that I showed you, there's a nice summary article about previous articles that looks for cardiac etiology of chest pain. And you can see from this list, the largest that was published in 2011 by Saleb et al. Had 3,700 patients evaluated in the pediatric cardiology office because of chest pain, and only 1% of those had a cardiac etiology. 37 out of the 3,700. So let's look into that study, and here is what that study showed. SVT happened in 16, pericarditis and myocarditis in a total of 17, and anomalous coronary origin was diagnosed in 4 patients out of the biggest cohort. Did any of these have pulmonary embolism? No. Did any of these have aortic dissection? No. The pericarditis and the myocarditis, they were all inflammation, so they all lasted more than a day. And then the anomalous coronary origin, that was the only thing that was kind of out of the blue, and that occurred during exercise. So chest pain happened during exercise. So you can see that there were many studies here. So this article was a meta-analysis, put it all together. So when you looked at all of those studies, these were the cardiac origins that they found in every single article from the 1970s to the late 2000 teens. Pericarditis and myocarditis were the most common reason for chest pain. And I totally agree with that because you can see that here and there. SVT, which doesn't really cause you a chest pain, just as I said, little kids are unable to articulate it. And sometimes they say they have chest pain instead of saying that actually they had palpitations. So that was a finding. And the next thing that was important was coronary abnormalities. When you look at all of these in the last more than 2 decades, pulmonary embolism was found in certain patients. Most of those patients had a previous heart surgery. And so that's important to know. And then there were some other pathologies found. But again, just think about it. The most important to remember here is perimyocarditis, maybe SVT, and coronary artery anomalies. So these are the cardiac etiologies that we need to diagnose. You don't need to diagnose Ehlers-Danlos syndrome in patients with chest pain because it doesn't happen. So bottom line, here is an insert of a chest X-ray with a cardiac silhouette. Chest pain in pediatrics, it happens because of something else. You got to think outside of the cardiac box because a lot of things can cause chest pain, just like a swallowed scissor. But what I want to say with this, obviously this is not true, but what I want to say with this, and that's what I tell to parents, I don't deny that you don't have a chest pain or your child does not have chest pain, but that chest pain just not coming from the heart. There is a lot of other stuff in the chest that can hurt. And most often in these patients, what really causes the chest pain is musculoskeletal. And I also explain why. So musculoskeletal chest pain it's the most common. It's probably more than 90% of all chest pains. It is precordial, it's right in front of the chest, or in the middle, or a little bit on the side. So it could be midsternal. A lot of times they tell me my heart hurts, doctor. Yeah, right. So, when they come that my heart hurts, it's a little more difficult to explain that no, that's not your heart, but they usually say something in the front hurts. The important thing, again, in the history, sometimes it lasts only seconds, like 5 seconds. It's really sharp. It's so painful that you have to stop breathing. Sometimes it lasts a couple of minutes. And another important part of musculoskeletal chest pain is that it stops you from take a deep breath, or it hurts even more when you are breathing. And then I ask them, so what moves when you are breathing? Your heart moves anyway. You can stop breathing, your heart's still moving. So what moves when you are breathing? The muscles in your chest cavity, the muscles and the bones. So that's exactly what hurts there. That's why it's musculoskeletal. And quite honestly, most of these are, so to say, growing pains. We always say there are growing pains in your hips and knees, but your sternum is growing and actually changes into bone. The cartilage changes into bone. So a lot of times that's what hurts in these kids. It usually resolves without any intervention. You don't even have a chance to intervene in that couple of seconds or minutes. So it doesn't require any therapy. So this is the most common chest pain, and you don't need any kind of test to figure out whether that chest pain was or was not cardiac. So what is the action item and what do I do when I see a patient with chest pain? I take a very thorough history. That's all what you need. You need to make sure, does it happen with exercise or it doesn't happen with exercise? How long does it last? Where does it hurt? What is the quality? How fast does it go away? Is it worse with breathing or is it not? And then obviously you can do a little bit of physical exam so you can diagnose hallmarks of Marfan syndrome or a musculoskeletal disorder. And basically that's the only thing. In the other part of the history is, did you have Kawasaki disease that I usually ask? And that usually gets diagnosed and treated in the hospital. It's very rare that somebody doesn't get diagnosed with Kawasaki disease because that's an acute febrile illness that doesn't go away by itself. So, next step, testing. Well, I mean, what do you need to do testing when you know that the chest pain lasts only 2 minutes? I don't need to do any testing because nobody on earth would convince me that for 2 minutes you had aortic dissection, but it went away. Or you had pulmonary embolism, but it also gone now. You had a little bit of myocardial infarction, but it's all good now. So that just doesn't happen. Or pericarditis. That again, it lasts half a day, 2 days, 3 days. So, when you took that in history, I don't need any other testing on earth. If you catch chest pain right at that moment, somebody goes to the ER and yes, I still have chest pain, and it now lasted for like 2 hours and it's right there. Well, then you have a captive audience, and great, then you start working up. And when you work up for, well, if it lasted for 2 hours, the two most common cardiac etiology is myocardial infarction and pericarditis. So you need to diagnose those two. What is the easiest way to diagnose it? EKG and troponin. So EKG is important during chest pain, not a year after, because you got an EKG 2 days after. Does it help? No, it doesn't help at all. If the chest X-ray was gone, are you able to diagnose a coronary artery abnormality at rest in a normal state with an EKG? No, you cannot. So the EKG is not useful. It's only useful during chest pain. And what can it show? Just like in this EKG, it can show ST segment elevation. That's exactly what you're looking for. Look at this ST segment elevation in almost every single lead. Lead 1, lead 2, more than 2, maybe 3 millimeters, precordial leads, even the lateral leads. So this is probably pericarditis. Another EKG, this is different and this is more concerning. If you look at the precordial leads, there is significant ST segment depression almost all over, but that's also present in the inferior region. This is not subtle. It's so pronounced that you cannot even see the QRS finishing. So this is acute myocardial infarction. So this is what you are looking for when you are getting a chest or an EKG. But again, it only helps during acute chest pain. So you did that, and then what do we need to diagnose with it? Perimyocarditis or myocardial infarction, which can only happen if you have Kawasaki disease or if you have that coronary artery abnormality. Um, what will give you a definitive answer? Well, perimyocarditis, it can be totally diagnosed by EKG. EKG and troponin are perfect. That can only already give you the diagnosis. Are you going to order an echocardiogram for chest X-ray? Oh, I'm sorry, for chest pain? Well, do you really believe that that patient has a aortic dissection? I don't think so. So we're not going to order an echo for that. Echocardiogram would be good to get the coronary arteries. Um, so you can diagnose coronary artery abnormality and a coronary artery dilation with the echocardiogram. So that is the only reason to get echocardiogram. Or if you are concerned that the patient truly has an active myocardial infarction, which you will send the patient immediately to the ER, so you probably don't need to even worry about it because that patient will be admitted. And as part of the workup, there will be an echocardiogram. Again, if you think about the patient truly has pulmonary embolism, are you going to wait for the outpatient echo? No, the patient goes to the ER, gets a chest CTA. And for all of these reasons, basically there is no use to order an echocardiogram. The only time when even the American College of Cardiology will get or recommend to do an echocardiogram in the setting of chest pain if that chest pain is exertional. You see, that's where the green light is on the bottom. Why? Because if you have chest pain during exertion, that means when your heart is really stressed, that's when it has some sort of problem, maybe ischemia, and then you have to look for the coronary arteries for a previous Kawasaki disease or an abnormal coronary artery anatomy. The other time when you can proceed with um, echocardiogram is when you had an abnormal EKG. And what kind of abnormal EKG will you find in a setting of chest pain? ST segment elevation. Then the patient gets to the ER, probably gets admitted, and you will get an echocardiogram at that point. Fine. The only other part here is the family history, which I kind of disagree with, because just because you have a family history of sudden death or cardiomyopathy, okay, fine. That needs to be worked up with an echocardiogram. That has nothing to do with chest pain. So that's a very different story. But again, just keep in mind, exertional chest pain is something that raises a red flag. Why? Because this can happen. This is a simple CT scan and a reconstructed image of an abnormal coronary artery anatomy. Both the right and the left coronary arteries are coming from one origin. The problem it is not that they are coming from one origin, but then the left coronary artery then goes between the pulmonary arteries and the aorta. That also wouldn't be a problem because it just, supplies the left side of the heart. But what happens at peak exercise, and that's why exertional chest pain raises a red flag. At peak exercise, your cardiac output doubles or triples. That means your pulmonary arteries and your aorta will dilate. As they dilate, they're going to crush or compress the coronary artery in between in every single heartbeat. So you suddenly, not so suddenly, gradually, as your heart rate and your cardiac output increases, you're going to have less and less perfusion of your left ventricle. And that's when you're going to have chest pain. So you're going to have chest pain during exertion. That's why exertional chest pain requires further workup. Unfortunately, this can also show up in sudden cardiac arrest because not just chest pain can happen, an arrhythmia can happen too. The other time where chest CT is useful, when you have pulmonary embolism, you can see this filling defect here in the pulmonary arteries, but that is not something that you have to diagnose in an outpatient manner. This is probably happening in the ER. And this is a cardiac MRI that can be useful to differentiate the etiology of chest pain. And you can see here part of the myocardium lights up. That's because of inflammation, gadolinium enhancement, and that is because of myocarditis. And in associated with myocarditis, usually the pericardium is inflamed, and again, the pericardium that can transmit the painful stimuli. So this is helpful for diagnosing perimyocarditis. So summary of chest pain. If it hurts right here and pointing with a single finger in front of the chest, that's usually not a cardiac origin unless it is pericarditis. But then, or what you need to ask, how long does the pain last? And if it lasts a few seconds or a few minutes, you can completely dismiss it because that cannot be a cardiac or even a cardiovascular origin. Again, reminder, ischemia, pericarditis, aortic dissection, pulmonary embolism. These are your 4 choices. If you don't think that any of these happened in a couple of minutes and then went away, the patient did not have a cardiovascular origin. Especially if it changes with breathing, that just confirms that it's musculoskeletal, and those patients do not need to come to see the cardiologist, or I'm happy to evaluate them, but they don't need to see the cardiologist in an urgent manner. When you have red flags, and I like this guy right under the red flag, is when you are having a real pain in the middle of exercise. That's what you don't like. So when you have excruciating pain, well, that's kind of concerning. And then, you end up coming to the ER with that. If the pain occurred in the midst of exercise and you see the patient in the office, I would say that's the appropriate patient to restrict from exercise and send to the cardiologist. If it lasts many hours or a day, that's concerning, and then usually can have a workup. If the pain is still present, EKG is the first way to go. And it's also concerning if the chest pain is followed by fainting or other signs of hemodynamic instability. Of course, that those patients should be evaluated right away and up coming to the ER. Another hallmarks that you can see, so if you have a big scar on your chest, well, you have to think twice about those, but usually it's not the first time they're gonna see a cardiologist, or you have some musculoskeletal abnormalities and you think about a disorder, then that's another good reason to come to see the cardiologist. So again, red flags, excruciating pain, pain that is in the middle of exercise, and pain that lasts longer than just a few minutes. All right, now we switching gears to syncope. I put those.
Dr. Rattensag, may
Yes.
I interrupt you very briefly? We have a
Yes.
couple of chest pain related questions. Maybe we could go through those super quick
Right.
before we move on. So the first one was, and I think this question came up while you were going over the slide with when to echo and when not to echo, but now with COVID, if that has changed any of the recommendations, do you ask about COVID, or should we be asking about COVID in these kiddos?
Good question. COVID infection does not cause cardiac issues that would require chest pain. The cardiac issues related to COVID infection are usually found in adults, elderly, that exacerbated a condition that was pre-existing. So that's the important part. So that's acute COVID infection. Then comes MIS-C, and MIS-C can cause coronary artery dilation. But usually MIS-C is diagnosed and treated in the hospital, and those patients get an echocardiogram just like the patients with Kawasaki disease. If some of those patients have coronary artery dilation, they will be actively followed by cardiology. So yes, I've never seen one that way because it acts different than Kawasaki disease, but potentially those patients can have coronary artery problems later on. So there is a small yes in there. And then the last one is the vaccination. vaccination truly caused perimyocarditis. So I treated many patients with appropriate cardiac chest pain. That vaccination or that era went away in 2021, May, June, July, August, and I have not seen those vaccine-related perimyocarditis ever since.
It's very good. Okay. Two more questions. One was, what about rheumatic heart disease? This was when you were going over your green and red flags. Rheumatic heart disease, where that fits in, and then PDAs as well.
Yeah, none of those cause chest pain. Rheumatic heart disease destroys the valves. Acute rheumatic heart disease could have mild degree of pericarditis, but then when you have pericarditis, you have pancarditis, and you will notice other signs. So it's almost never chest pain that happens first in rheumatic heart disease. Again, it's not out of the question, but usually that's not something that you need to even think about. And then once you have rheumatic heart disease with an ongoing cardiac damage or residual cardiac damage, those patients are hooked up to cardiology. And again, they usually don't have any reason to have chest pain. So rheumatic heart disease is not something that we have to think about chest pain. PDA doesn't cause chest pain.
Perfect. Okay, last one for this is, if the pain lasts for 2 minutes during exertion and then resolves while still exerting. These are great questions. I would have absolutely no idea how to answer them. Very glad we have you.
Yeah. So, I think even though I'm very straightforward in my evaluations and I rarely get any testing, when it happens in exercise, I raise the red flag and I dig deeper, and I discovered a coronary artery abnormality in a 5-year-old kid, which I believe still that a 5-year-old kid cannot tell me, do I have really chest pain? I mean, are you kidding me? You just cannot articulate it. But then when a mom told me that he screams every single time when in judo practice they have to do this and that and jumping jacks, and like, okay, that doesn't sound right. And so we got an echocardiogram. So, when it happens at exercise and kind of consistently or more than once, I gonna restrict them and just gonna go and look for. And what do you look for? Coronary artery abnormalities. So you order an echocardiogram, you need to order a Kawasaki disease kind of echo so we can look at coronary arteries.
Thank you.
Good
Thank you so
question.
much. Yeah, great questions. Okay, those were all
All
the
right.
questions for chest pain. I will let you get along with syncope.
Thank you. So here are the wonderful misnomers of like fainting spells and I don't know what. The best is the last one, syncopizing. I don't think so that's a word. So let's just go and dial it in. It's the appropriate word is syncope. And then here the American and European societies defined it as an abrupt, transient, and complete loss of consciousness, with usually a rapid and spontaneous recovery. And this loss of consciousness is because of cerebral hypoperfusion. So when you are standing and you stared in the distance for like 3 seconds, is that a syncope? No, because you were standing. No, so there are sometimes when you get dizzy, is that a syncope? No, it's not. So it truly is the loss of consciousness that matters here. And again, I could copy this slide from chest pain to syncope because a lot of kids will have it in their childhood. It's again about 1% of all pediatric ED visits. This is now number 2 most common reasons of pediatric cardiology visits, somewhere around 10% of all the visits. And yet again, less than 1% is caused by a cardiac etiology, exactly like chest pain. So what kind of etiologies can it be? It can be neurologic, such as seizure, we go over that, psychologic, like hyperventilation, I can make myself faint if I really want to, metabolic, which is mostly hypoglycemic, neurally mediated, and that's the new wording. You can call it neurocardiogenic, that it has nothing to do with neurology and cardiology. It's just called like that. And that's the old vasovagal, but we'll describe this too. And then really less than 1% is cardiac. So same thing. How do you find that 1% or less than 1% in the haystack? Well, let's just go over the causes of syncope. Again, and this is the most common. The rather it is, the more common it is. Neurally mediated, which is neurocardiogenic or whatever you want. Previously vasovagal. Vasovagal is that it's very specific actually. So what is the most common that I see, most common etiology of syncope? You get up from sitting, you get dizzy, and you faint. That's called orthostatic hypotension. And I would be very careful, and please don't diagnose it with postural orthostatic tachycardia syndrome, because everybody on earth has postural orthostatic tachycardia. That's called physiology. You get up from seated position, your heart rate should go up, and I will explain you why. POTS, or postural orthostatic tachycardia syndrome, is when that tachycardia lasts beyond 10 minutes. So how many of us truly do the test to wait for 10 minutes and continue to measure the heart rate to diagnose this? So this is not a diagnosis that we just give to patients who increase their heart rate when they get up. Everybody does that. So again, the most common is orthostatic hypotension. Neurologic, usually seizures. You need to ask the right questions. Post-seizure, post-ictal period, and so on. How did it exactly go? What started first? Did you feel it? Whatever. Psychogenic, anxiety, panic disorders, panic attacks. It even comes in, factitious disorder, malingering. This is very rare. I don't see this in my evaluations in patients with syncope. And a metabolic, and then it's weird that they put dehydration there, but I guess hypovolemia can be. This is also pretty rare. And the only thing I truly see is dehydration or hypovolemia. So again, the most common of syncopes that we do see is like this. You're standing too long, you're gonna faint, you pass out there. Or you go from one way to another when you had lots of blood in your head, and you turn upside down, and then all the blood goes to your feet, and then you faint. So without joking, let's just look at the most common reason, which is orthostatic hypotension. And you see when this lady is laying down, there is a lot of central blood volume. So the heart is full, has great cardiac output pushing to the brain. At the moment you get up, and unfortunately, I have to tell you, once you turn 25 years old, you're kind of too old to have this. This happens only in the very healthy, really young kids. Most of the time, the teenagers who grow super fast and their blood pressure just does not grow with them. So when they get up from laying down or seated position, when they get up, their skeletal muscles are not yet activated. So all the blood just pools in their lower extremities. The central blood volume gets smaller. So what happens because of that venous pooling, the blood volume gets lower, the stroke volume gets lower because there is not much blood to push out. Cardiac output drops abruptly, and basically you just get cerebral or brain hypoperfusion. Your brain does not get enough blood. That's all what happens. And so what happens, I used to tell them, your brain says, time out, I'm going to push this body back down into horizontal position, so you do faint. And before you faint, a lot of other symptoms can come. Those are the prodromes, so to say, and those are all there because of cerebral hypoperfusion that is a little bit insidious, meaning that it happens over a couple of seconds, even up to 10 seconds, and you get dizzy, you get blurry vision because you don't have enough blood to your occipital cortex, so your vision is blurry or dark or tunnel. You can hear things, you can feel sensations in your fingers because your brain just not functioning well. And to the point that there is not enough blood, that your brain just stops functioning, and that's when you pass out. So if you stand up long enough, you're gonna get, and you don't pass out, you're gonna get from that lower cardiac output 2 extra steps, which is your baroreflexes counter-regulate. If you pass out within 15 seconds, you don't even have a chance for these to happen. So you're gonna just pass out in that 15 seconds if your blood pressure is truly low. But you counter-regulate, so you increase your heart rate, because increasing your heart rate increases your cardiac output, and then at that point, you're not gonna faint. So again, when you get up from here and you have orthostatic hypotension, is it normal to increase your heart rate? Hell yeah, and that's not POTS. That's not any syndrome. That's just normal physiology. If you happen to stay in the same stage and you have to stand in a hot environment for too long, your increased heart rate beyond 10, 15 minutes, it gets to a point when your blood pressure is still dropping, you try to regulate with increased heart rate, then suddenly it turns the other way around, your heart rate drops, and that's when this happens with the soldier who gets out, and that's called vasovagal syncope. So that's a very specific syncope when you stand too long and then your increased heart rate does not compensate anymore. But again, the most common that happen with pediatrics and adolescent is just supine to upright position and because of orthostatic hypotension. The second most common is because of reflex syncope. When you smell something gross, you see something gross, you get a blood draw, and this is what happens. You have an 8.8 second pause, sinus pause, and you basically have no cardiac output and you pass out. Is this a cardiac problem? No. This is just normal. It's very exaggerated vagal response. Are you going to die with this? No. Once you faint and you stop smelling gross, the heart rate comes back to normal. This is what happens with babies' breath holding spell. Then they get really, really vagal. I had a patient in my office who was screaming, bloody murder, screaming to the point he stopped screaming, barely breathing, went to breath holding. I was listening to the heart rate. It went from 180 to 120 to 60 to 30. At that point, passed out in front of me, stopped having breath holding spasms. Heart rate came back nicely and came to it, right? So this is exactly the same. There is nothing wrong with the heart. It's wrong with the psychology, right? So you have to treat the breath holding spell, and then you have to decondition this individual for smelling or seeing gross stuff. But the patient does not require a pacemaker just based on this symptom. Same thing with orthostatic hypotension. Is there anything wrong with the heart? No, there is nothing wrong with the heart. Patient just needs to drink more or be more careful getting up. All right. Well, let's concentrate on syncope with the cardiac origin because this is what we need to sort out. And how do we sort them out? Well, just need to know what can happen. So what is that we really need to sort out in a cardiac syncope? Cardiac issues when suddenly the blood stops flowing to the brain. And that's VFib and non-perfusing VTach, which in my mind is just like VFib. So a non-perfusing tachyarrhythmia. I again put SVT there in 3 brackets because I've only seen one single individual who fainted with SVT, who was playing a tennis game, super dehydrated, and in the midst of that had SVT and kind of stumbled across the field and fainted. Usually kids do not faint with SVT. Those are usually perfusing rhythms. So again, non-perfusing tachyarrhythmia, VT with VFib. AV block with super low heart rate, okay? It can happen acutely because of myocarditis, and that I've seen once in the last 11 years here, or it can happen progressively, and that patient is usually hooked into cardiology. But it can happen because of AV block and bradycardia. And the other third and fourth cause is not going to happen to you because these are terminal cardiac conditions. When you have such a bad heart failure that you cannot walk anymore to the bathroom, and you have such a low cardiac output and hypertension, and you can faint with that, or your pulmonary hypertension is so bad that it limits the cardiac output, you have acute cor pulmonale, and you faint with that. Inevitably, these patients would have other symptoms before, so this is not what's going to happen out of the blue. So out of the blue, you need to find out etiologies that result in AV block or VTVF, sudden cardiac arrest, basically. And those that you need to figure out is the inherited arrhythmia syndromes, and there are tons of them, and I'm gonna show you what kind of syndromes are, or cardiomyopathies. These are the syndromes that can suddenly make you develop ventricular tachycardia or ventricular fibrillation, and that can cause sudden cardiac arrest or syncope if you come back to it. So what are these? Well, this is what happens. Whatever they are, this is the end result. From your normal sinus beat, it goes to VT, then it deteriorates to VF, it goes all over the place, and you can imagine that about 5 to 10 seconds into this VT, but especially in VF, this patient faints. So that's exactly the only cardiac origin that you need to figure out in previously unexplained or unaccounted for syncope. So what are the lesions? Long QT syndrome. Diagnosis made by EKG. See, the QT is super long. Great. Another long QT syndrome. Diagnosis made by EKG. Super long QT. Long QT1, long QT2, long QT3, doesn't matter what type, diagnosis made by EKG. What happens with them? This is what happens with them. And this is, I know it's fuzzy, but I like this tracing because you can see the torsion, the torsion of the points. So this is VTach VFib in a patient with long QT syndrome. And this is what can happen, and that's what can lead to syncope. So what do you think? What happens with patient in syncope? Well, lucky for the patient if the patient wakes up after a syncope, because this is sudden cardiac arrest in my book. So those patients usually wake up after a while, and sometimes they need CPR, or sometimes the syncope lasts more than just like 30 seconds, 60 seconds. They are out for sometimes minutes or even more. Another diagnosis, short QT syndrome, where the QT is short. Diagnosis made by EKG. Same thing happened with these patients. They can get into VTVF. Another diagnosis, Brugada syndrome. Diagnosis made by EKG, an ugly-looking V1, V2, where there is ST segment elevation. What happens with these patients? Pretty similar, but it happens at sleep when you have a slower heart rate, but they can get into VT, which can deteriorate to the ventricular fibrillation at the end. Another diagnosis, it's called CPVT, catecholaminergic polymorphic ventricular tachycardia. This is a diagnosis that I can only make with an exercise stress test and not with an EKG. And we'll think about it exactly why is this happening. It's part of the red flags that I would like to mention later on. Here, the syncope happens during exercise. So you can see there is ventricular tachycardia that happened or was initiated in the midst of exercise. Another diagnosis, hypertrophic cardiomyopathy. Diagnosis made by EKG. I don't want to even spend time on this. Next one, dilated cardiomyopathy. Diagnosis made by EKG. You can start to feel the pattern here, right? Concerning syncope, underlying cardiac etiology, diagnosis made by EKG. WPW, diagnosis made by EKG. So evaluation of patients with transient loss of consciousness that you are thinking about a cardiac origin, it's in the history, maybe a little bit of physical examination, and this is the only time when I say, please get the EKG right away. So syncope, EKG right away. Chest pain, only if the EKG is still present when you have, well, I'm sorry, only if the chest pain is still present. That's when you get an EKG. So syncope, what do we do? History is again the
So
most.
sorry,
Yes.
Dr. Runza, can I super quickly interrupt you just to let you know that we actually only have about 2 more minutes?
Oh, geez. Okay.
Um,
I only have a couple of slides left.
yes, just to give you the heads up. Thank
Okay.
you.
So again, in syncope, most important is history. If it happens without a prodrome, if it happens not by orthostatic changes, but it happens during exercise, it's kind of concerning. And you need to do a physical exam, but you don't find anything in these patients. So you really need to get an EKG to figure out. So when is it okay? If it happens with postural changes from getting up from sitting to standing, on a hot day, standing in line, after a hot shower, combing your hair, straining, and so on, typical prodrome visual hearing changes, dizziness, and usually quick recovery. So this is all the past, and this is all in history. When there is no pass and red flag is during or immediately after exercise. So again, same thing like chest pain. Exercise related, I don't like it. And then obviously if it requires CPR, you're gonna make it to the cardiologist, no mention. And if you face plant without any recollection, so you didn't have any idea what was coming, you just face planted in the middle of something. Those are concerning too. Again, just quickly show you when to do echocardiogram. Same thing like chest pain. If it happened during exercise, get an echo. Sure, sounds good. If the EKG was abnormal, get an echo. Sure, that sounds good. So, but you don't need to deal with this so much than the cardiologist itself. So here's the summary slide. Chest pain and syncope, super common. 99% of benign, 1% is really associated with a potentially lethal cardiac condition, and that's what you need to sort out from that haystack. And how do you do that? It's really in history. The red flags are if it happens during exercise, if you had a heart surgery before, the most common reason, pericarditis, myocarditis, coronary artery abnormality, and for syncope, it's these inherited arrhythmia syndrome and cardiomyopathies. Diagnosis made by history and EKG. EKG you should get only if you have still concerning chest pain or you had a syncope before. I would always get an EKG. Echocardiogram can totally wait later, even after the cardiology referral. So that was my last slide and the summary of it. We're ready for some questions if you have a minute.
Oh my gosh. That was actually perfectly timed on the dot at 1 o'clock. I'm very impressed. I don't see any questions right now, but because of that, we're going to go into the poll questions quickly and have everyone answer those. And then we'll just go over the right and wrongs with you very quickly as well.
Okay.
If anyone does have questions, though, feel free to shout out or just put them in the chat now.
And you can ignore question number 5.
Okay.
What is question number 5?
Oh, untitled.
Oh,
Like it.
okay.
Or yeah, just choose one for fun.
I know, I kind of want to, let's see what people do.
So true or false? 1 in 5 children will experience chest pain during the. Yeah, that's true. Good job, everybody. True or false? 370 of the 3,700 patients, 10% had a cardiac etiology in syncope. Well, that's false because only 1% had it. Good job, most of you. Or shall I wait?
No, you can go ahead. They can still answer.
Sounds good. True or false? One of the complications of Marfan syndrome, Ehlers-Danlos syndrome, and Lewis-Dietz syndrome, aortic dissection, which usually occur in young children ages 5 to 15. Wow, thank you for the tricky question. This is false because It does not occur in young children, and that is very important to remember. Yes, those can result in aortic root dissection or aortic dissection, but it happens in young adults. I've never seen anybody below 20 years of age having any issues with that. So the answer is false. And all of these are warning signs of fainting spell, so to say. Well, yeah, those are all kinds of symptoms that can happen in benign syncope.
Now the question 5, who did we get? Answer A or answer B? Summer.
Answer A.
Answer. Wonderful. I don't see any additional questions. Just thank yous, and that was a great presentation. I very much agree. I honestly had no idea that there was so much similarity in regards to kind of red flags, warning signs, what to look out for, and when to get the EKGs and echoes. So this has been extremely helpful. I am going to be passing this information along to all the coming residents as well, because this is definitely something that we see even in the hospital, I think, surprisingly often.
And I think no cardiologist would ever get offended of being consulted for chest pain or syncope. It's still appropriate to refer, but then you guys can choose which one is really, really needed or urgently needed, and which one doesn't need to be seen urgently.
Exactly. And you know when to think about EKGs, especially EKGs over echoes. Oh my gosh.
Right. Yes.
Okay.
Oh, I promise that here are my references if somebody wants to take a screen, and this is where most of this was derived from.
And we'll upload everything to the website as well, to the Echo website. And are we allowed to upload the article as well, Summer? Is that possible?
I can. He sent it to me today, so I can upload that as well. And thank you, Dr. Bratenshaw. There's
so
many
much.
thank yous in the chat.